Okay, it's just now 2 o'clock, so we'll give it just a minute longer. I have Kevin, Keith, Linda, Troy, all logged in so far. If I missed any committee members, can you please let me know?
Jacob Carroll's logged in.
Oh, my apologies, Jacob. I didn't see you log in.
No worries. Thank you.
Okay, so if all of the committee members don't mind to turn on their camera so we can establish a quorum, I would very much appreciate it. One, two, three, four, five. Okay, it does look like we have a quorum. So the first, I'll turn on my camera since I'm speaking. Sorry about that. This is Erin with the Department of Medicaid. I hope everybody's having a wonderful Monday today. The first thing we wanted to do is vote for a chair and a co-chair. I had Troy Walker and Keith Smith both reach out to me. They're both interested in either being the chair or the co-chair. So if the committee would like to vote on that, I'm not sure if Troy and Keith have a preference on chair or co-chair for themselves. They typically work in conjunction together with constructing the agenda, getting that to me, and then also representing your TAC in the, to the MAC meeting. So Troy or Keith, do either one of you guys have a preference on your chair or co-chair position?
This is Keith speaking. Troy or I are fantastic choice. Whichever one gets it. We're both very active in EMS in Kentucky. I'm on the board of EMS. Troy's very active with Kappa, so I think either way we'll have good representation.
Troy, do you have a preference?
Yeah, really, I don't. I was just trying to think how often we'll need to be there in Frankfurt, and Keith is a lot closer than I am. That was my only thing I was seeing. I don't mind the co-chair or whatever. It doesn't matter to me, guys.
As of right now, all of the Zooms and the Macs, all the Zooms, excuse me, my brain's not functioning. All the TACs and the Macs are via Zoom. I believe some of the TACs and the MAC have thought about maybe having a in-person meeting come the springtime. So that would, so as of now, there may be one in-person meeting to travel, but if you would rather be the co-chair and have Keith be the chair for traveling purposes, that makes complete sense. So if one of the other committee members would like to make a motion for Keith to be the chair, can someone make a motion and then someone else second?
I'll second that.
Okay, Keith, you are our chair. Can I have a committee member make a motion for Troy to be a co-chair and then a second?
I'll make that motion.
I'll second.
Awesome. Great, guys. Well, I will send you the agenda template. Typically, as long as you try to get that to me, we ask at least 10 days prior to your meeting. Sometimes I know that's not always doable. So that way I can get it out to staff and the MCO partners and get it uploaded on the website. So okay. Thank you guys for your willingness to serve as our chair and co-chair. So Keith, I will turn this meeting over to you and we can start with the new business.
All right, awesome. Thank you, Erin.
You're welcome.
As we get started, I will just do a real quick announcement. The fact that the EMS Legislative Task Force that House Bill 777 formed has concluded their business as the official legislative task force. They did issue a final report. There were a number of recommendations that were made, and K-Beams is doing a deep dive in all of those recommendations to see what is the low-hanging fruit and what effort is going to have to be made going forward in the other areas. And I say this because part of the agenda today, we may ask to table simply because we have not had the opportunity to really discuss it as a group or as a subcommittee at the K-beams level yet, but we'll get to that point in just a moment. So starting up with new business, first point of order is the EMS psychiatric transport. And as far as the possible impacts of dialing 988 versus 911, I can think of several issues that could potentially cause, but for the folks who asked to have that added to the agenda, if you would like to go ahead and bring up what your either concerns or positives you may have on that. Was there any specific provider or committee member that had concerns about the possible impact of 988 versus 911?
I have some information from Medicaid, so if you'd establish that there's no questions or comments, I'd like to give an update from Medicaid.
Sure, go right ahead.
Okay, so my name is Leanne Fitzpatrick. I'm a behavioral health specialist under the Behavioral Health Initiatives Department of Commissioner with Medicaid. And I was the program manager for our mobile crisis planning grant. So basically what that meant is we got a planning grant from CMS to kind of beef up our mobile crisis. We realized that our mobile crisis was not defined as well as it should be. So along with that, and we did a needs assessment throughout the state, talked to different providers, stakeholders, and transportation was one of the top two needs and issues that we have. So what we kind of have done on Medicaid side is we're proposing to start behavioral health secure crisis transportation. That would be a new provider type that will offer two types of services. One would be if someone calls 988 and that call cannot be triaged over the phone, then the 988 call center can dispatch a mobile crisis team. So the mobile crisis team goes out, meets with that person, and with that person and the mobile crisis team, it's determined that that person needs a higher level of care. So at that point, the mobile crisis team can continue their mobile crisis response along with the transportation to a higher level of care. And the second part would be that if EMS is requested to transport the individual, say someone is there at the ER and they need to go to a higher level of care, that would be the second part of being a provider with the behavioral health secure crisis transportation.
Okay.
They will receive payment for the transport, and if someone enrolls to be a behavioral health transportation provider, actually I'm going on to a different bullet, but let me stop there. Kentucky may also consider adding an alternative destination and or treat no transport to the state plan. If there's a need for active rescue from 988 or 911, there would be a warm handoff. And if it's an active rescue, then the mobile crisis team would not be dispatched. Collaboration efforts between 988 and 911 currently they're underway and discussing, someone calls 911, but they really need 988. How am I going to transfer that call? What's the process with that? That's currently underway. Any questions? I think that's my last point. Yes.
Yeah, just real quick, off the top of my head, as far as the mobile crisis team, looking at this from a perspective of at what point does an ambulance get called because of either self-harm actually occurring or the threat of self-harm? Is the mobile crisis team going to make that determination once they get word of a crisis in motion, or who makes that actual call?
So if someone calls in and they're in an active state of self-harm, 988, then that would definitely go straight. That 988 call taker would definitely send that straight to 911. Let's say that the person's calling in and they're suicidal and they may have some means, and the call taker would kind of assess for safety in the environment that they are. And then when the mobile crisis team gets that dispatch or gets that deployment, continuous conversations are going to be had. If sometimes, a practitioner can feel in their gut that it's not really a safe place to go. So a police officer can be called, maybe parked where the person can't see them, to be there just in case. Or if, in that situation, they feel like a 911 EMS or police, of course, that mobile crisis person will be calling as soon. So it's going to be a continuing assessment of the situation from the call coming in to the mobile crisis team on the way. And once the, mobile crisis team gets there. Now, if someone's on the phone, suicidal, yeah, I have some pills. Yeah, I have guns in the house. So that's going to be an automatic co-response of police and the mobile crisis team.
Okay. How many folks would be responding with the mobile crisis team?
So it depends on the provider. CMS has given us an outline that it has to be at least 2 active participating providers that are responding. Now, one has to be a behavioral health practitioner that is able to conduct an assessment in the state. For an example, an independent license, say LCSW, and the other member of the team could be another provider or peer support, a case manager, as long as there's 2 people actively responding to that. We prefer there be 2 people go on scene. Say if you had 2 peer support go on scene and the behavioral health provider is through a laptop or a tablet where they can be seen and be heard.
Mm-hmm. Okay. I'm sure that safety and security is a primary
Yes.
part of the discussion here. And that's something I would just encourage that the folks working together on this mobile crisis team
Yes.
keeps in mind, because I think all of us in the EMS world have been on scenes that have gone south in a really, really big hurry. And having law enforcement literally right around the corner was the saving grace.
Right.
From a horrible news story being on that evening.
Right. And currently the state 988 implementation team is working on a triage framework so that every 988 call center will be following the same triage framework. So if you got a call in Eastern Kentucky and Western Kentucky, they'd be handled in the same way. And the same thing would initiate a mobile crisis deployment or transfer to 911.
Mm-hmm. Do you have a estimated or potential time frame that they're looking to have as far as a response time to one of these type of events?
Yes, 60 minutes from when the call is deployed. Now, we know that not always you're going to get somewhere in 60 minutes. So if the mobile crisis team can foresee them not getting there in 60 minutes, then they're to call, get on the telephone and make some type of communication with that person. Sometimes it might be that the call is transferred, warm handoff to that mobile crisis team, and they talk to them the whole way there.
Leanne, I got a question. This is Troy.
Sure.
Okay, you got a patient that's not wanting to go with anyone against their will, let's say. Will there be a part of this team that can facilitate that paperwork to where there is an authority to go? And I know ambulance, that's one of our problems, is we don't have the authority to hold them. Will the other mode of transportation be able to do that, or somebody that's not wanting to go and not in custody?
So just say someone that you feel like needs to go to the ED or go to like a crisis stabilization center. Well, that's kind of the hope of redefining the mobile crisis, is that having a behavioral health practitioner that's there. Sometimes the fear of EMS and the ambulance, sometimes there's just that fear, and not always, and I don't mean any disrespect at all, not always the EMS person has that behavioral health training to where the behavioral health provider could talk them a different way, have them see it in a different way. And then if they're absolutely refusing, and then we'd have to go the 202A route. Does that answer your question?
Yeah, I just didn't know how easy that would be obtained, Okay, I get you.
Yeah. Yeah. I know there are so many, we can't sit here and talk about every situation because it could be, you never know what you could run into. But definitely safety is definitely top priority of the practitioner and of the individual calling. And it might be that the mobile crisis team is the provider that that person sees already. They may already know them, have a relationship.
Mhm. Yeah, there's also a course. I just spoke with Lee Richardson, who is a mental health specialist at Baptist Corbin. And she is now offering a mental health first aid course. That's an actual certification course. It's 7.5 hours long that she does. And then I believe there's a whole group of folks that are doing it now that
Yes.
we are going to be looking to do for all of our Baptist Health EMS folks because of the expanded practice with behavioral health that Baptist is doing. And I'm sure this is something that we'll have to speak with the other hospital providers that are in there, and also all of the EMS providers in the state to see how many people are willing to do this. And I think probably the number one thing is for everybody to focus on is the de-escalation.
Yes.
Because if anything causes a scene to go south, it's usually when a patient starts to spool up and persons there may not either say the right thing, not knowing that they're not saying the right thing, or just the color of their shirt triggers the person, which it could be something as simple as that to get a bad outcome. So
Right. And mental health first aid is an excellent program, and mental health first aid, say for EMS workers, for teachers, for children. So it's a program that's devised for the certain audience that it's pertaining to. Yes.
And where you were talking about that there would be a reimbursement rate for whomever does these transports, if they do need to transport. Do we have a ballpark idea of what we're looking at? Is it going to be a flat fee? Will it be similar to a loaded mile fee that we get currently for doing transports? Has there been any discussion about that yet?
There's been lots of discussions. If the service is added to the spa, it'll be a directed payment. And then it'll be through the MCO, so providers can negotiate payments with their MCO. As a fee for service policy, there will be a fee, a blanket fee put out there. And then providers would negotiate with the MCO on their rate. We're looking at a flat rate for a run and then mileage. But that's kind of beyond me. But I know we talked about that. We talked about the providers that would be, there's going to be specifications for that vehicle, of course. I think of kind of like a cab that they have a, plastic or some type of compartment that keeps them separated so that, they can't affect the driver. And then with the driver would be a support person so the driver can focus on driving. So there will be some specifications. They will have to follow all state regulations on transportation, but we hope to have that in our mobile crisis effective October 1st. That's our goal.
Okay, and will that fall under the Medicaid DOT non-emergency transport guidelines?
No, sir. It'll be their own provider type. The spa definition will live in the transportation spa. And then the behavioral health team under the commissioner would be those that will follow and enforce the policy for those behavioral health provider types. I will send Aaron a copy of what we have put together, and it's a draft so that you all can read that and kind of understand it a little better. Another thing is with the spa, to remove that a ambulance can only transport to a hospital. We're looking at changing that to just a facility so that they can get paid to go somewhere else. We're going to update the non-emergency transportation reg to where it states right now that if you have a vehicle in your house, you cannot receive an EMT. So we're looking to remove that as well.
So Keith, is this just a on a subtitle 2 here, licensed by EMS providers? Is that an accurate statement for this non-ambulance transportation?
That's a great question. I think maybe we might want to look at changing that, because there's a chance that this could be a niche for a non-emergency medical transporter that's not a licensed EMS provider, but yet can meet the vehicle requirements to be able to do this transport. So we may want to look at maybe opening it up to where it's not simply licensed EMS providers.
I just don't want to get into that ballpark of stretcher vans and stuff like that that we've tried to avoid. And I
Yeah,
don't know if that was kind of falling into that category.
yeah, no, I'm right there with you. I've been doing a lot of research on stretcher vans for hospital-based transports that don't require or don't meet the EMS criteria, and there is no such animal in the DOT regulations. So I think we need to better identify, besides just saying licensed EMS, I think we need to, obviously, we're not gonna be able to sit here and define it all today, but I think we need to take a look at who are the providers that would be able to operate these vehicles, and not just say that it would be an EMS provider that would be doing the active transport. Now, if it were an unstable patient that has actually caused some form of self-harm, and they need to be transported by an EMS unit, then by all means. But if it's a stable behavioral health patient, I could see a couple different scenarios where potentially hospitals could use a vehicle other than an ambulance, whether it be a wheelchair van that has been modified or otherwise, in order to do the transport, thereby not tying up a mobile emergency room for a stable behavioral health patient.
Right, and if that EMS provider, the county, city, whatever, they would be able to enroll us as this behavioral health transportation provider type and be able to get reimbursed.
Okay, I guess the concern there is besides just the EMS being able to enroll in it, can hospitals or other care providers enroll in order to do those transports if they've got a method of being able to do the transportation safely?
Correct.
Okay.
I have sent that document to Erin, and she can send it out to you all, and you all can read it and review it and say this won't work or this work, add comments, however you like.
Okay, fantastic. Thank you for doing that. And thank you for
Mhm.
briefing us on that. I think that's a positive step in the right direction. As far as the 988 versus 911, I know this is probably an elementary question, but will there be any type of media advertisement on this, so that we don't get people getting confused on what number to call for a
Yes,
behavioral
there's
health issue?
that question is a very popular question. And so SAMHSA, the Federal Substance Abuse Mental Health Association, if you're familiar with SAMHSA, they didn't want to do a lot of advertising before July because not every state was ramped up and had the staff and had everything to go. So it is now slowly coming out. I live in Georgetown, and I have recently seen a 988 billboard. Now it's kind of off to the side. You kind of have to look for it, but social media, there's a lot going out there. If you go to SAMHSA's website, I can put that in the chat. They have some branding that you can use. They have, you can order pamphlets or some information. So advertising is coming, but it's coming slowly.
Keith, a lot of the dispatch centers already have it, and through the dispatch centers. I know Nelson County Dispatch Center is pushing it hard.
Yeah, Angela Roberts, who is the 988 administrator for the state, she has really been active in getting 988 PSAPs and 911 PSAPs, excuse me, and 988 to talk together and to understand each other, understand what's needed. But mainly right now it's on social media. Why would I call 988? If you're feeling sad, if you're feeling blue, this is when you would call 988. So
Okay,
it's coming.
fantastic. Since there are other communication centers that have already been on board with this, if there hasn't been any reaching out to Kena APCO as a group yet,
Yes.
there may have already been. Okay. I
Yes,
was gonna say that would be a good start because they touch just about every dispatch center in the state.
Yes, she did. She actually spoke to them, I think last week or whenever they had their last meeting. She just talked
Okay.
about that this morning. So she did speak with that group.
Fantastic.
She comes from a disaster relief background, so
Mm-hmm.
she has a lot of knowledge of all that information in the state. So yes, she is speaking to those groups.
Okay, great. All right, any other discussion about the EMS psychiatric transport? Okay.
I
Hearing
put my
none,
email in the chat. If anybody has any questions after this, feel free to reach out and email me.
awesome. Thank you, Leanne. Appreciate it. All right, going down to item B, discussion of expanding House Bill 8. This is the area that I was asking that we look at potentially tabling simply because we have not had an opportunity to discuss this at K-Beams or any of the subcommittees because of the number of items that the Legislative Task Force has asked us to take a look at. So if there is no heartburn about it, I would like to request that we table the discussion of expanding House Bill 8 unless somebody just wants to go ahead and put something out there for us to consider. If not, we'll put it back on the agenda for February.
Motion to table it.
All right, we got a motion to table.
I'll
Second,
that.
who is that on the
Second
second?
that, Jacob.
Okay. All in favor of tabling? Aye. Opposed? All right, very good. We'll go ahead and table that one until February. All right, this next issue, C, about pre-authorization for transportation out of hospital. I'll speak for just a second on it and open it up because this is a very hot topic for EMS across the state. The issue that I can speak of for the EMS providers that report to me is that from the perspective of the form, it's not set up in such a way that a hospital can answer all the questions, and it's not set up to where EMS providers can answer all the questions. And some of the demographic information it's asking for, EMS has absolutely no way of being able to get, such as the ICD-10 codes. Once we do a patient transport, because we don't diagnose, we basically treat what we see. We have no way of knowing what the hospital has actually coded the patient. And if the hospital doesn't provide that information specifically to us, which typically they don't, it's impossible for EMS to be able to complete that part. And asking a hospital to do the form, there's no way that a hospital can know the exact mileage that the crew is going to be doing. There could be a detour on the road. You know, we could look at MapQuest all we want, but what's actually happening on the streets is something totally different. So from my perspective, this is causing a very significant issue. One of the EMS providers that one of the hospitals that I work with, the EMS provider called saying that they're over $50,000 in the rear on reimbursement because they have not been able to get the pre-certs either authorized in time or been able to get reimbursement on an appeal. And if you don't mind, I would like to call on Ms. Basham. If you don't mind, Linda is one of the owners of 911 Billing and Consultants. She deals with this quite often. Linda, if you wouldn't mind, could you speak to some of the issues that you're seeing with these forms and the ability to get them done in a timely manner?
Well, I think you've addressed it quite well, Keith, because hospitals have the ICD-10 codes, but you're right. Neither side fully understands and is capable of completing those forms, at least not to the detail orient that they're requesting, that they're really looking for. And many of the services do not have their own dispatchers that can take any information when the call is received requesting the call transfer. So, you know, if the call center, the county call center is taking that call, they have no idea what to ask the hospital for EMS to be able to complete the form. it's a no-win situation. We have a lot of counties that are simply not getting paid for Medicaid runs because they don't have the ability or the ability, they don't have the reserve of staff to be able to chase these down before they make the run. The hospital wants them out. They don't want them out at 8 hours later. They want them out within a short time frame. And there's just no one that can the answers to all these questions without taking a great deal of time to get that prior off before the trip.
And to clarify, we're not speaking about the behavioral health transfers right now. This is basically
Right.
any non-emergency transfer that is coming out of a house or hospital that has been called into an EMS provider to be able to complete. I saw the question that come up on the chat about that. Is there anybody else have any other comments about that?
Yes, I'd like to speak, Keith.
Sure.
Because I'm one of the services right now that are struggling with pre-authorizations. I am one of those services that does not have an ambulance specific dispatch center. I use the county resources. All pre-auths that we do for Medicaid patients, MCOs, are all retroed. There's no possible way we can get these done prior to transports because non-emergency is such a large scope of our runs because per CMS guidelines, I mean, it's got to be pretty much a hemodynamically unstable patient to be emergency and not need pre-auth. So an acute or a cardiac chest pain that's needing to go to a higher level of care, even though they're stable, the ER still wanting to get them out of there. But we got to do that. It's still considered a non-urgent because of the patient's the way that's regulated, the way that's posted and the guidelines we go by. So to get that pre-auth prior to transport is just something we can't do. So it's got to be retroed. And you're right, we can't get all the information from both sides. The ambulance service is struggling. The hospital don't want to be responsible to do it like they are PCSs because there's no stipulation that says a hospital has to do that. And that's what I'm running into. The hospital is going to stop doing it. So there's a large problem. And I'm considering most of these the ER transports. I'm kind of on the fence with the maybe an inpatient at a hospital going somewhere else where they got a little bit more time. I guess my biggest concern is these ER patients.
Yeah, even for the inpatients though, I spoke to one of our hospitals and the house manager has been trying to file these pre-certs through the portal and everyone that she has done has been denied and kicked back for one reason or another. So even on the inpatient side, there's not any success in getting these done prior to the transport being done. Now, to the end of being completed on the back end or retro, it does help being able to get paid. However, that does cause folks to have to go back, get back into the patient record, get the information they can get. Some of that information may not be attainable. And I'm not exactly sure, Linda, you might be able to correct me, but one of the payers is simply, if it's not done beforehand, they will not pay out a reimbursement retro. It has to be done beforehand, which considering the scope of what type of impact this is having on our EMS providers, I'd like to suggest we come up with some alternative or putting a pause on these forms until we can figure out how EMS providers and hospitals can work together with the insurance companies in order to get the information that is truly needed. And I say truly needed because a lot of the information, well, I don't want to say a lot, some of the information that's on these forms is the same exact information that's already being put on the PCS form or on the patient's face sheet that gets sent in. So there is some duplication of effort that's going on here. And with the number of patients that all of our providers are moving across the state, a duplication of effort is not in our best interest at all, nor can we simply do it. So I would like to hear from the Medicaid folks and any of the MACs that are on to see if there's any possible solutions to this or potential remedies.
I think it's especially Anthem that will not do a retro.
Okay, thank you, Linda.
Well, and also, Keith, Medicaid doesn't require this. It's the MACs that are the ones requiring this. So none of our
Sure.
Medicaid patients have ever required a pre-authorization. So I'm kind of curious about that aspect of it as well.
Yeah, thank you, Troy, for clarifying that. I was kind of lumping it all together, but you're right. Thank you.
Do we have any MCO representatives on the line that would like to address those issues?
This is Meredith with Passport Babalina. We should not be requiring an auth for non-emergent ground transportation. If you're getting that from us, please let me know.
No, that's correct. Passport does not.
Okay, thank you.
Yes, this is Dan Brunner from Anthem. Do you have specific codes that are being submitted? Are you able to share those so we can do some research?
There's only a handful of them. It would be the base rates,
Are they
the
the T codes?
AL 427, 426, just the base rate codes from, we doesn't necessarily ask us for a mileage code, but that's AL 425, that it's going to be depending on the patient's condition. And it's like Linda said, Anthem's not retroing it. WellCare is probably one of our worst to have to deal with. We can't, just like Keith said earlier, we can't, even when you go back, they're just denying it for all kinds of different reasons, never consistent. So
Are they claims denials? Because a lot of these codes don't require prior auth for us.
our claims are being kicked back because there's no prior auth on them.
Can you give me the specific codes? Because there are T codes as well. There are some A codes as well.
It's AL 428, AL 429. I'm sorry, wait, AL 428, AL 426, the non-emergent friends.
T 2008, ain't it?
That's the T
That's-
codes I'm familiar.
Okay, well, that's the conversion for Medicaid.
Okay.
Dr. Berner, if you'd like to drop your email address into the chat, I can send that out to the TAC meetings or TAC members, excuse me, and have them send you some follow-up information for you guys to look into.
Thank you, right here.
And this is Dr. Cantor with United Healthcare. We should not be requiring a prior auth either for this type of transport. And if you are, let me know, please.
This is Samantha Harrison with Humana Healthy Horizons. We'll do some digging for you all and get back with you. We do have a retro policy as well. We'll share that information.
Okay, thank you.
Anyone from WellCare on the line?
Yes, this is Kathy Davis, and I'm definitely taking notes as you all are speaking, and we can, especially if I can get a couple claims examples emailed to me, I will dive into this and definitely respond back.
Kathy, if you could drop your email address in the chat for me, I'll make sure to get that over to the members.
Do it right now. Thank you.
Thank you.
Well, thank you all for the comments on that. Okay. All righty. On that, as far as you all looking into this, we all greatly appreciate you doing that. In the interim, I'm just wondering if there can be until we get an answer one way or the other, is there a chance that we could pause these forms so that our providers can have the opportunity to catch up on the claims that are outstanding now, and then maybe set a date coming up in the future where we can turn the pause off to where everybody's ready for it to move forward so that our providers aren't so far in the rears on their reimbursements. Maybe this is something that simply can't be done. I don't know, but that's I don't think I'd be doing the position right if I didn't at least ask.
This is Samantha Harrison with Humana Healthy Horizons. I think we have to do some research on our side, Mr. Smith, and we also, to undo a requirement for prior authorization requires some system configuration. I believe I'd probably, if we are requiring PAs, I'm not an expert on our PA list right at this moment, I apologize. If we are requiring PAs, we would have to do some system configuration to put something like that on hold. But we're certainly willing to consider after we research and get information for you. Okay.
Okay, thank you.
And just real quick, I just want to add, I can tell you that we're receiving denials from every one of the MCOs for no authorization. I just kind of want to throw that out there because a couple of y'all come on and said you're not requiring them, but we are getting denials, and Linda can probably attest to that as well.
I just don't want this to be an American ship. I mean, I don't want it to happen to anybody, but.
If it's okay with you, I can get everybody's email address, send them out to the members, and if you want to maybe add it under old business for the next meeting for a follow-up. So the MCOs can
absolutely.
review some of the information you send and see if we can come to a resolution then.
Sure. And what I'll do too is put the notes together from this, from the minutes, and at the next K-Beams meeting, we'll go ahead and put this out to all of our providers so that they know that everyone is actively working on the issue to see what we can get worked out. I think the thing that has got a lot of people scared right now is not knowing, is this going to be something that we're going to have to contend with going forward, or if we're going to be able to get the problem fixed in a halfway reasonable amount of time. We've had one EMS provider tell one of the hospitals in Kentucky that if they can't start getting paid and they're expecting the hospital to now make the payments that they should have gotten through the providers, that they're going to stop performing all non-emergency transports. Well, if that happens, it will absolutely cripple that particular hospital because given their geographic location, this one particular EMS service is the primary non-emergency provider right now. And honestly, asking the hospital to pay upwards of $50,000 for outstanding claims that should be insurance claims is putting a big hit on the hospitals as well. So thank you all for being willing to take a look at this and see what we can do going forward to get it resolved, whether it's altering the form, making sure everybody's on the same playing field, whatever the case is. I think moving forward on it is going to be helpful versus where we're sitting right now. So I appreciate all of you being willing to do that.
Mr. Smith.
Oh, I'm sorry.
Sorry, this is Samantha Harrison. I just want to make sure I have the codes down accurately. A0428, A0426, and I think somebody else said T2008. Is that accurate for MCOs that you're talking about having problems with?
That was, I think, Troy that mentioned that. Troy just had to jump off the line real quick. He had an issue come up with his service.
Oh, I'm still here.
Oh, I'm sorry, Troy.
Yeah, I'm still here.
Yep.
I got a, yeah, I think
That is
I think
correct.
that's a crossover, T 2008. Yes, yes.
Okay, awesome.
I mean, Keith, I think some of the most important things, I mean, to just kind of start looking into it is one, Medicaid. Medicaid has never required this. This is the come on with the MCOs, and it's grown over the last 7 or 8 years. It becomes more and more and more from the initial start of that. So I'd like to see Medicaid look and just see for sure in the state. I mean, they don't require it. So is something changed in the regulation, or is there something there we could look up to see what the specifics are for Kentucky Medicaid and non-emergency transports? So I think that would be a start. And then, if we can't fix or stop some of the, especially the ER transports, at least get everybody on the same page and be consistent across the board would be the other thing. If we're going to do it, at least be consistent. But those two things is some of my bigger questions.
Well stated. Can anyone from the Medicaid office add any insight onto that?
Hi, this is Angie with Medicaid. I don't know that I can specifically answer all those questions. If the fee-for-service Medicaid members do not require prior authorizations, that doesn't mean that the MCOs cannot. They simply develop their prior authorization list. I mean, as long everything has to be medically necessary, as you very well know. So we do review their prior authorization list, and if that's what they're currently doing, then it's been approved by DMS.
Just out of curiosity, and maybe one of the MCOs can offer more information on it, but what is specifically different between the need of the pre-certs and the PCS forms that we're turning in now with our runs? And do we still have to do the PCS and the pre-cert form, or will one supersede the other?
Mr. Smith, this is Samantha again with Humana, and I'm sorry for my ignorance, but when you start using acronyms like PCS, I'm
Sorry.
not quite sure what you're talking about
I
because I'm
apologize.
also not a coder. So
Oh, yeah. Okay.
anything you can help us out with, we're happy to review for you and get back to you.
Sure. Sorry about that. It's the military coming out in me. The PCS is the physician certification statement that EMS has to have signed by either a physician, registered nurse, case manager. I believe there's 4 or 5 other classifications of staff that can sign off on it, indicating what the patient condition is that warrants the transport. And it's a form that EMS has had to complete for, my goodness, I would say at a minimum the last 14, 15 years. So now the pre-cert form comes along that we have to do, even though we're already turning in a form that's got a signed explanation as to why we're doing the transport. It seems to me that it could be either one or the other. And if it can't be the PCS and it's going to have to be the pre-cert, then let us drop the PCS requirement so that we're not submitting dual information.
Thank you for the clarity. I really appreciate it.
No worries. And please, everybody, feel free to call me Keith. I hear Mr. Smith and I think of my dad still, even though I'm 56. So please feel free to call me Keith.
Okay, Keith, then I want to add, it's always just good to have examples when these issues arise with the MCOs. I know that Aaron's going to be gathering the MCOs' email addresses for you all to utilize so they can look into this a little bit further. So I know that will be very helpful in determining by the next time. You did mention, I did want to ask, you did mention that you are working with hospitals to help get these prior authorizations for non-emergency transportation. Did I hear that correctly?
Yeah, I'm working with the Baptist Health, the hospital system I work for. They call me asking what are we supposed to do about getting these forms completed. That's where I'll communicate with our billing provider and see what they can provide on our end, on the back end. So there's talk that goes between the hospitals and the billing companies and the EMS providers. And one thing that I will say that this issue has helped us with is communications between the EMS providers, because of how many EMS providers this is adversely affecting. It's got people talking that hasn't talked in a while, which is a good thing. But because the reimbursements are affected, it's not such a great thing. So it's kind of, one hand to the other hand. So yeah, it's
been going on. And I'm going to tell you, 2 or 3 years ago, when I started the research and talking to legislators on this one issue, pre-authorizations has been an issue for a while. The fix to this was trying to help come up with a TAC committee. That's how the TAC committee, that's how we started this whole project, meeting with legislators, and they said, hey, y'all need to come up with an ambulance TAC committee. So this was one of the main reasons for getting this group together. So pre-authorizations is a very large problem across the state of Kentucky. So Kentucky Ambulance Providers Association is in every county in the Commonwealth pretty much, and we see it across the board. So this is a huge problem for pre-hospital.
Well, I can tell you something we can do at DMS. We can reach out to each MCO to see what their policy is on prior authorization for non-emergency transportation. Now, if you're seeing this also for emergency transportation issues, you know, that's another issue, but we can also get that information for each MCO and share that. I think what the MCOs need from you is some specifics as well, though, on some of the denials that you're getting.
You know, I have no doubt that the folks that are with the billing companies that are on the line will be able to get that information to them, including all of the codes and what the HCPCS codes are in particular, which I believe, based off of what we've talked about so far, is basically basic life support transportation code and associated mileage that goes along with the BLS code. There can be the occasional ALS, but typically if it's ALS, it may fall into the emergency category in which it would not require the pre-cert. And I'm not aware of any emergency transports that have been denied based off of the pre-certification. So I believe this is strictly on the non-emergency side.
I think a lot of it where you look into though is thinking it was emergency because maybe it was a ST elevation MI or something like that was going out of the ER. And they're thinking it's emergency, only to find out a couple weeks later that they wanted a pre-auth and they denied it though. I think the definition between emergency and non-emergency is kind of a hot topic as well, because that gets a lot of agencies in trouble where they think it should be emergency.
Right, right.
And I did want to clarify, it is just not emergent that we received the denials on. I misspoke a while ago when I said the AO427, but it is just non-emergent calls. We do not see this on emergent.
Okay.
Very good.
So, Steve Bechtel, Chief Financial Officer here in the department. I got kicked off a while ago, so I don't know what all was just said, but my suggestion was, and maybe Angie, you were touching base on that, is, you know, I think one, we need to figure out from each MCO what the prior authorization requirements are for each MCO. I heard that, I think Molina at Passport and Molina, I forget which way that goes, but I heard that they said that they don't have prior authorization on this matter, but then I think, and I'm not sure if your name, but Ms. Evans said, it says D Evans on my screen. So if that's your name, hopefully that is, but Ms. Evans said that she was getting denials from all. So maybe a few examples of how Passport specifically, what denials you're getting from them, that would be helpful for Passport to look into. But we, you know, just given the codes, that's one thing. We need to look at the codes, see if there's a prior authorization for those codes. But I think also, I don't want to inundate, you know, every billing agent to send me 100, you know, send us 100 claims, but we do need a few examples of these claims just so that we can go back into the system or have the MCOs look into their systems to see, is there an issue that's kicking these out? So maybe that's what you all were talking about while I was trying to get back in, but if so, I apologize. If not, that's my recommendation. So.
Yes, Steve, that was it. And I don't know if you heard me say that, but we can also, DMS can reach out to the MCOs to see what their policy states.
Okay.
For non-emergency prior authorization.
Okay. Thank you.
I can send a follow-up email to all the MCOs and request that and get that information over to the TAC.
Thanks, Aaron.
All right, very good. Any other comments on the pre-authorization? Or if everyone's done, we'll go ahead and switch down to item D. All right, hearing none, let's go ahead and move down to D, which is the presentation of DBH in February meeting. Aaron, can you give a little insight on what that is?
Yes, from my notes from last month, or not last month, pardon me, from October, is that Leslie Hoffman had offered her group to give a presentation from the Department of Behavioral Health. my guess is that Leanne touched base on several of those things today when she was talking about the mobile crisis. So she just wanted to offer a presentation on some of the things they were working on in that area, if the committee so desires.
Okay. Liam, was there any other follow-up or any other information that you wanted to offer under this line item?
I'm sorry, which one?
Under
D,
the presentation D, presentation from DBH in February meeting?
I apologize. I don't know anything about that.
I can follow up with Leslie Hoffman. She was unable to be on today.
Yeah, it's the Department for Behavioral Health, but I apologize.
Oh, no worries. No worries. And folks, I apologize. I'm still learning names and who you're with. So if I call out a name and it doesn't sound familiar, it's probably because I've butchered it. So I apologize. All right, we'll go ahead and move down to item number 5, general discussion. Does anybody have any topics to bring up under general discussion?
Keith, I did want to bring up one thing. I'm sorry, this is Erin with Medicaid. In the chaos of trying to get the new Zoom link out and get you guys voted in, I forgot to get you guys to vote on the minutes from the October meeting. So if you guys have had a chance to review that and you want to call for approval of the minutes, normally that's done right after you establish a quorum.
Sure.
And so my apologies on that.
No worries at all. For the folks that have had the opportunity to review the minutes, are there any recommended changes or otherwise? If not, I'll call for a motion to approve the minutes from the October meeting.
Motion to accept minutes.
A second.
I'll second.
Who was, it didn't pop up on the screen.
Jacob.
Okay, thank you, Jacob. All right, all in favor of accepting the minutes as written?
Aye.
Aye.
Opposed? Abstain? Motion passes. Thank you, Aaron. Okay, if there's no other general discussion under recommendations, I believe the only recommendation we got right now is that basically everybody do what they have committed to under the pre-cert form and to do the research. The billing companies were going to submit some examples to the MCOs so that they could see what is occurring in the field. And we will look to readdress the situation at the next meeting in February, which we've got it down as February 27th from 2 to 4. Item number 7, MAC meeting representation.
The next MAC meeting is January 26th from 10 to 12:30. So typically the chair or the co-chair attends to give a brief summary of the meeting and if they have any recommendations for the MAC. Also, if you guys, neither of you are able to attend, any of the committee members can attend on your behalf.
Okay, very good. On those, would you be able to send out, if you do it via Zoom or otherwise, would you mind sending the meeting invitation out with the link included?
Yes, sir. I can send that out to you. I believe I sent it out to all the chairs, but since you didn't have one, I can go in and add you guys to it.
Okay, that'd be fantastic. I appreciate it. Okay, again, next meeting for the Medicaid TAC is February 27th from 2 to 4 p.m. Eastern. If there's no other business that needs to be discussed.
I will, if you allow me real quick, Steve
Absolutely.
Bechtel again, Chief Financial Officer, Medicaid. We did get approval from CMS on the calendar year 23 preprint for House Bill 8. I just want to be transparent with this group here so that everyone knows that it's coming. But we're still awaiting on the SPA approval of it, which is just for the fee for service piece, the smaller piece. So just want to let y'all know where those stand.
Okay, and Steve, if you don't mind, I may reach out to you offline to get a little bit more information because part of this I'm still having to educate myself about
Okay.
because I haven't been involved in the past. So
Yeah,
if you don't mind.
we can talk offline, but I will tell you that we have been, Jim Duke from the Kappa as well as Joe Pruitt have been very instrumental in working with us. And we have a meeting. We can always send that to you to where we meet every 2 weeks to discuss the program. So.
Okay, fantastic. With
Right.
with both Jim and Joe on there, I've got no doubt that EMS is going to be well represented.
Okay.
Awesome. Thank you very much. All right. If there is no other business, we'll go ahead and call to adjourn. Is there a motion to adjourn?
Motion to adjourn.
Second?
I'll second.
Thank you, ma'am. All in favor?
Aye.
Opposed? All right, very good. Motion passes. Thank you all very much for your attendance and thank you for the discussion on all the topics that we had today. I'm sure that we will be waiting with bated breath for the information that comes back from the MACs having to do with the pre-authorization. So I do appreciate everybody on the call. And I hope everybody has a wonderful holiday. Stay safe and please stay warm.
Thank you. Have a great holiday.
You too.
Everybody.
Happy
Thank you all.
holidays. Have a great afternoon.
You all too.